very happy to welcome you all for today's session of Professor AD's Virtual Clinics for Postgraduates. And today we have our guest speaker, an eminent faculty who is famous nationally as well as internationally for his work on bone and joint tuberculosis. So today, Professor Anil K. Jain sir is the guest speaker and he'll be talking to us about bone and joint tuberculosis. Sir is currently the principal at the University College of Medical Sciences, Delhi. He is also the Dean and HOD of Orthopedics at Faculty of Medical Sciences, University of Delhi. Sir was the past president of Indian Orthopedic Association. He is currently the chief editor of Indian Spine Journal as well. And he was the editor of numerous journals. Few among them are Indian Journal of Orthopedics and Journal of Bone and Joint Surgery, American version. Sir has undergone most of his spine surgery training at UK, Nottingham, as well as at Edinburgh. Sir has numerous publications to his credit, more than 139 publications, and most of his publications have been cited around 4,000 times. It's a great honor to have you, sir, in our program. A warm welcome from all of us at IORAS. Sir is also very instrumental in indexing our famous journals, Indian Spine Journal as well as the Indian Journal of Orthopedics. And he was the first to frame the guidelines for bone and joint tuberculosis treatment for the government of India. So with these few words, I'm very happy to welcome Professor Anil K. Jain, sir. Over to you, sir, to proceed with your presentation, sir.
Thank you very much, sir, and thank you, Jay, for giving me this opportunity. And I always love to be part of any thing asked by Professor Devadas, sir, because I am his. He will not find another big fan as more than Anil Jain, because I'm his big fan. And I have been associated with him since '89 when he became the president. So for me, it is an honor, and I'll try to be as coming to expectation as best as my capability. I think, dear students, I would all like that you all should read these index TB guidelines, which are available on Ministry of Health Family Ware's website, and page 75 to 84 are orthopedics. They are crisp guidelines, and they are very useful. Now, how it is difficult to create any of these activity for extrapulmonary, because variation in the evidence is very poor on extrapulmonary tuberculosis. And that is why it was a very good effort to create guidelines on extrapulmonary TB. And in that, 15 disciplines have created guidelines, which includes bone and joint as well. I think the biggest part while framing these guidelines, the question came how to get evidence to every word you write in the guidelines. And it was very difficult to come up. So it just an idea came to our mind that let's write some questions, let's pose questions to ourselves. So we posed about 200 questions to ourselves when a patient with a suspected spine TB, hip TB, or different joint TB comes to us, and how sitting at the clinics, the question comes to our mind that how to investigate, how to diagnose, how to treat, how long to treat, when to stop, when to operate. And then we tried to gather the answer to those questions, evidence-based answer to those questions. And then out of that 157-page document, we created 8 pages index TB guidelines. Now, when all that was done, then it suddenly occurred to our mind that why not those 157-page document, which may be useful to our trainees. So we compiled with some more basic information in the form of this book. So this book, to my mind, gives an insight how the guidelines are being created. It's not moving. Yeah. So what I'm going to do in this talk, I'm going to talk about certain basic pathological and investigative issues as a tuberculosis bone and joint. Then I will deal upon the spinal tuberculosis in continuation, so that, and some of those issues which we will discuss as spinal tuberculosis, I'll keep on speaking about the limb joint tuberculosis as well. Now, well, this tuberculosis has lived in symbiosis since time immemorial with the human being, but it is the French physician Laennec who diagnosed, who seen the tubercle, identified the tubercle for the first time late in the early 18th centuries. And it was a common cause of death globally, but then gradually with the improved sanitation, it had started declining in the West, even the early part of 19th century, before even ATT was invented. But even now, it causes 7,000 deaths per day as per WHO. And out of all pulmonary tuberculosis, 1 to 2% patients are osteoarticular tuberculosis. Well, you may get in some of the literature as 1 to 3%. And you can understand the magnitude that 1/5 to 1/6 cases are in India. And almost 1/3 of the world's population is infected. And in developing countries, the worst part is that 75% of TB cases are in economically productive age, so younger age group. And lifetime risk of developing TB in 5 to 10% in an HIV negative population, and 50% in an HIV positive individual. As far as India is concerned, 40% of the population is infected with mycobacterium, and we have a huge incidence of cases, 2 to 8 per thousand life population have active bacillary pulmonary tuberculosis. While if you take as the sputum negative, then the number is multiple times, 3 times or 4 times more. But then coming down to bone and joint tuberculosis, 50% of the bone and joint tuberculosis is spinal TB. Now, there is a race going on between the virulence of organism and resistance of the host. And that is why I said there was a sharp decline in TB in the West immediately after improved sanitation in 1900. And after ATT, it came down drastically, significantly. However, even in the Western world, because of HIV infection or fast moving of population, immigration or social deprivation, lots of patients are on immune suppression. A lot of patients are being reported from the developed countries as well. And drug resistance has started coming up as a menace. I think we have to remember one thing: whenever it is HIV-associated tuberculosis, it is mainly extrapulmonary. And this is what is a location-wise: vertebral 50%, remaining hip, knee, foot, elbow, hand, shoulder, and others in that order. And you must remember that more than one lesion, say if a patient comes with one lesion, when you get an MRI, you find 7 to 10 or even 25% patients have another lesion elsewhere, which is not symptomatic. So it is a localized manifestation of a systemic disease. And this skip lesions are more with the HIV positive populations. Something about mycobacterium. Yes, this is most common is a mycobacterium tuberculosis, while others, Africanum and bovis, they are lesser chances. They are thin rod with round end, 2 to 2.5 micron long, strict aerobes. They grow rapidly in the oxygen and non-motile without capsule. That is why they are strict aerobe. That is why the pulmonary lesions are multibacillary. The bacterial count is 2 huge, while the bone and joint extrapulmonary tuberculosis, they are paucibacillary. These organisms resist staining by usual method. They are acid and alcohol fast, and they grow very slow and grows only in certain media enriched with egg, potato, and serum. Well, there are certain atypical microorganisms, and they are also being divided into photochromogens and non-photochromogens. Now, you have to understand this very clearly. if there is a pulmonary lesion, and from there, the organism may have disseminated by currently hematogenous disseminated or has disseminated before, lying as dormant bacteria. Now, whenever there is a reduced immunity locally or systematically, then this organism there starts multiplying, and this multiplying organism, they are surrounded by polymorphonuclear leukocytes, which gets replaced with the monocytes and macrophages. And as a result, phagocytosis, this monocytes and macrophages, the phagocytosis of cytosis of bacilli takes place. These are converted into epithelioid cells, and multiple epithelioid cells fuses to form a Langerhans cell, and the central part of the lesion is surrounded by a ring of lymphocytes. So that's how a tubercle forms. And now this tubercle, if there is no necrosis, then it remains as a hard tubercle. But then generally in the center, there is a necrosis, and it becomes a caseous necrosis, and it becomes a soft tubercle. And now these multiple tubercle fuse to each other and may become a big tubercle. And the necrotic part and the central necrosis may moves as a liquid pus. So now there are two kinds of disease. One where there is a lot of caseation. So it is an exudative type of disease with a huge collection of pus, or there may be simple granular type of disease where there is not much of pus. It's a granular type of disease. Now, when this thing is occurring in a joint, it may start in the synovium or may start into the bone. But ultimately, one, whether it starts from the synovium, it becomes affects the bone, or if it affects the bone, then it opens into the joint and then the synovium, and finally both are infected. And that's how the joint is destroyed. Now, this cold abscess, which is formed in some of the lesions, which runs along facial planes, along vessels, and along nerves, and may manifest in it far away from the affected joint or from the vertebral column. This phenomenon takes more with the vertebral column because at each segment, intercostal nerves are coming. So the pus may track along the intercostal nerves to manifest distally, or may open into the muscle and become a sauce sheath, or into the sauce muscle or any other muscle. And that's how the cold abscess manifests. Now, in cancellous bone or a small bones, some of it is seen as a cork-like sequestrum, and some of the sequestrum is formed primarily in the cancellous part of the bone. Now, when this pus breaks open, then sinuses are formed, and this is the usual pathogenesis. Now, clinically, this is more common in first 3 decades of life, although no age is immune. They manifest as with the insidious onset, monoarticular and monoosseous involvement, but generally they have an associated constitutional symptom, and then the local signs and symptoms start appearing as pain, painful limitation of motion, muscle atrophy, regional lymph node enlargement, and night cries. A role of trauma. Almost all patients, they give history of trauma, but it is not the trauma that has caused the tuberculosis. In fact, trauma has created area of reduced immunity at the bone site, and that is why the reactivation has started taking place. So that is why most of these patients, they give history of trauma, or it is the trauma has brought the pain which was subclinical become obvious with the trauma, and that is why role of trauma is being is communicated by every patient. Now, it is most important that there is always a delay in the diagnosis of osteoarticular tuberculosis, and this has been reported worldwide because in the early symptomatic, early phase, early pathogenesis of disease, this may not be symptomatic and may not be, we may not be able to diagnose clinico-radiologically. We are able to diagnose clinico-radiologically in established case only. And that is why in all those articles which were published before MRI era, they says that it is quite common for a diagnosis to be made late in the disease. However, if patient is symptomatic and you suspect, then these are doubtful cases, and histology by any method, tissue must be procured. Now, differential diagnosis for any single joint pain could be chronic subacute monoarticular arthritis, chronic abscess, chronic draining sinus, chronic swelling, subacute and chronic osteomyelitis. These are the differential diagnoses. Now, if you do blood investigation in these patients, they have a relative lymphocytosis, low hemoglobin, raised ESR. Well, Montague's test is non-diagnostic, may be positive in countries which are endemic for tuberculosis, because each one of us has already undergone a BCG vaccination, and each one of us has already might be having a subclinical exposure of disease. So Montague's test alone is not diagnostic. It may be just supportive in a symptomatic joint. In a symptomatic suspicious, this test will be positive. But on this positivity, you cannot label it and can start treating. And these are the ways where biopsy is to be taken. Now, if you aspirate a synovial fluid, generally they show leukocytosis, predominantly polymorphs. The glucose content is reduced than the normal, while in pyogenic, generally it is absent. Protein would be elevated because it is exudative, and with a poor mucin clot. These are the findings in synovial fluid. Now, when a patient has come of a monoarticular arthritis and with this kind of a blood finding, and you got an X-ray done, a patient may be having a chest X-ray, has to be done in all cases, and patient may be having a concomitant chest lesion, or may be having evidence of old tubercular lesion. But regional X-ray shows a localized affected osteoporosis. You could see the regional osteoporosis. The joint line becomes hazy. Joint space gets reduced. There may be a soft tissue swelling on some of the X-rays. Joint space is reduced. You can compare here. And the bone may have gone into collapse. And this joint, in the extreme case, may have sublux, dislocated, and migration, or some deformity have occurred. So these are the X-ray findings sequentially in a different joints. One may get a sequestrum formation, as here in these patients, or this caseous tissue may undergo a calcification, or a subperiosteal new bone formation may be seen, or dystrophic calcification. Calcification beyond the confine of bone may be seen, and that is a hallmark feature of tuberculosis. In children, damage to physeal growth plate. So you can see a tubercular lesion on both sides of the physis, and that is why the differential diagnosis of destruction on both sides of physis is tuberculosis and chondroblastoma. Now, when you start treating these X-ray changes, remineralization starts appearing, and this you could see here, remineralization started appearing. Bone trabecules become sharpened, joint space becomes sharpened, and sometime in early phase, if you have started treated, even the joint space start appearing. So these are the changes one appreciates on plain X-rays. Now, there is no imaging available so far which can ascertain healing response, whether it is MRI, whether it is any other investigation. It is only the plain X-rays which are useful to demonstrate objective evidence of improvement to the ATT. That is why it is important, before starting an ATT, plain X-rays of the part has to be done. And that X-ray becomes the most important 2 months down the line when you want to compare with the new X-ray, whether the radiological finding, remineralization has appeared, whether trabeculae has become sharpened, or joint margins have become better, or joint space has appeared. Now, bone scan, I'm just for the sake of completion, it used to be a good one important investigation. Whenever a deep-seated lesion we were not able to diagnose before 1985, when we were students, this was a very important investigation. It is sensitive. It shows a hot lesion, but lacks specificity. It can only give us a finding where we can suspect that something is happening in which part of the bone, when you are not able to clinically ascertain, localize the lesion. Because we know that increased uptake is observed in osteoporotic fracture, infection, stress fracture, healing traumatic fracture, degenerative OA, and malignancy. Some malignancies, not all. And that is why bone scan now, with the advent of MRI, bone scan is not being done for investigation of osteoarticular tuberculosis. Well, CT scan, yes, certainly it gives a 3D localization of bone destruction, particularly small lesions, marginal erosions, which cannot be appreciated on plain X-rays, but it has a more important role in guided needle biopsy, so that you can procure tissue in a deep-seated lesion by CT-guided biopsy. Magnetic resonance imaging is the gold standard because we know that it shows edema or inflammation better, and even the soft tissue delineation is best with the magnetic resonance imaging, and that is why now magnetic resonance imaging is the gold standard for diagnosis of inflammatory pathology. Erosion of margin of bone and dystrophic calcification cannot be appreciated by magnetic resonance imaging. Now you have to remember that MRI does not yield any specific diagnostic feature for joint tuberculosis. However, it is a sensitive indicator of presence of early lesion. For specific diagnosis, clinical and lab findings are required. This is applicable to all peripheral limb joint tuberculosis. However, for MRI, for spinal tuberculosis, MRI still could be a diagnostic, which I'm going to tell you a few minutes later. Well, ultrasonography, we all know it is useful for soft tissue abscesses, demonstration of deep-seated soft tissue abscesses, and it may be very important to know, suppose a SOS abscess patient has, and which is tubercular, and we are treating it with ATT, and we want to know how its response to ATT, then the behavior with the treatment 3 months down the line, if we get the ultrasonography, then it's a good tool to see the response on the size of an abscess and the content of an abscess. But it is a good modality for early diagnosis of a joint effusions. Now, if you have taken aspirates from different fluids, what is the possibility of demonstrating organism? Synovial fluid only 10%, synovial tissue 20%, regional lymph node 30%, osseous cavity or dysarthria only 10%, and positive culture in 30 to 60%. So this is in general for a joint tuberculosis. Now, serology, IgG, IgM, well, it is said they are sensitive, but they are not specific. And that is why it is very clear now that any serological method is not to be done at all for bone and joint tuberculosis. Well, this was the question which was used to be posed when we were students, that 20% cases diagnosis still may not be ascertained in spite of getting all that done. Now, with the last 10, 15 years, we have worked on this area, and our diagnostic acumen has improved with the new things, which I'm just going to talk a few minutes later. Well, we all know that extrapulmonary tuberculosis has a lower bacterial paucibacillary and hence lower bacteriological diagnosis and source detection. I think I would recommend, because now I will be talking about most of the spinal tuberculosis and will be telling you the specific information for the joint tuberculosis, but most of the diagnostic and treatment will be the same for spinal and tuberculosis. So I will be categorically taking spinal tuberculosis now on. I would recommend that all postgraduates should read this review article, which was published in 2010, Journal Bone Joint Surgery, British 2010, and then 2020, this in the Bone and Joint Surgery American in 2020. I think I would say these two review articles tells us how we have moved in next 10 years from 2010 to 2020 as far as managing tuberculosis spine is concerned. And I think every postgraduate student must read these two review articles. Well, we know that great changes have taken place for diagnosis and management, and the outcome has improved with the introduction of ATT. And that is why the whole evolution of management is described as pre-chemotherapy, post-chemotherapy, and now. And now, because of development in surgical facilities, better diagnostic and imaging and pathological, and introduction to implant uses in surgical facility. So the outcome has improved quite a lot now. And that is why whenever we will be talking about spinal tuberculosis, we will be comparing the outcome in the three different era. Well, in goal of treatment of TB spine in a pre-chemotherapy era, before 1950 was a sanatorial treatment, and it used to be healing of lesion with natural immunity. And that is why the end point was death or severely crippled in almost over 50% instances. Now, then ATT came, and not only the ATT came, around 1950 onward, Hodgson developed transthoracic anti-decompression and surgery for all. So this was the radical surgery for all, and this was the invention of the Hong Kong group led by Hodgson. However, there were a large number of surgeons who were proponent of extrapleural decompression without decompressing the lesion, without going through the thoracic cavity, and they advocated surgery for defined indications. And that's how the middle path regimen came. So that's how from 50 onward, the whole world was divided between these two subsets of surgeons. But then goal of treatment between 50 to 90 was healing of lesion by ATT and surgery. But the endpoint was residual kyphosis and sequelae of paraplegia, because our diagnosis was clinico-radiologically and sequelae, and that is why residual kyphosis and sequelae of paraplegia was the endpoint. Now, with all improved imaging, improved diagnostics, we are able to diagnose them early. We are able to start and treat early, and we are correcting and we are preventing the deformity and correcting the deformity. And that is why in 1990 onward, we attempted that endpoint should be with no or minimal deformity, with no or minimal sequelae of neural deficit. Now, first of all, I will concentrate on diagnosis, how we have evolved. Well, as I said, it was clinico-radiological diagnosis is only possible if one has a classical lesion. Now, if one has a all classical finding as a demineralization, lot of joint space, fuzzy and obliteration of disc spaces, anterior loss of anterior bony height, kyphotic deformity, prevertebral abscess. Now, it means by this time patient already had, this is a clinico-radiological diagnosis, patient already had a deformity and patient may have the neural deficit. So it's already very late. Now, patient must be symptomatic till this stage is reached. Now, we should aim that we should be able to diagnose before this deformity develops, before neural deficit develops. And that is what is the present objective. And that can be understood like this. The disease starts as inflammation in a paradiscal area. And as a result of inflammation and the disease, this subchondral bone and the bone become weakened, subchondral plate is weakened, and disc starts herniating, obliterating, manifesting as a reduced disc space on X-rays. Gradually, bone starts losing anterior bony height and kyphotic deformity started appearing. And this disease tissue pushed into the spinal canal manifesting as a neural deficit. So this is a pathology of the disease. Now, if patient is in the inflammatory stage, to the severe classical form of deformity, patient is symptomatic most of the time. So if on the basis of these clinical predictor and imaging predictor, if we take these patients for a CT or MRI, and MRI is the gold standard to an MRI, then we should be able to diagnose this before deformity has come, before neural deficit has come. And this is what is the current teaching, current aim, and current plan. So what is a suspected case? Patients with persistent localized pain for 6 to 12 weeks or more in an endemic area, with or without constitutional symptom, with or without local tender, with or without X-ray pointer. And these are the X-ray pointer. You could see reduced disc height. You could see slight obliteration of lordosis and slight localized increase in prevertebral soft tissue shadow. So now this is a suspected case. We must undertake MRI in these patients to diagnose it before a classical disease comes. Now, we know that cervical spine, this is a normal cervical spine. This is a normal prevertebral soft tissue shadow. So in a cervical spine, before even bony destruction is obvious, increased cervical, the prevertebral shadow is a good pointer for an underlying disease. Here, there is a suspected destruction of bone, and you could see such a huge prevertebral collection. And similarly, cervical dorsal junction, such a huge trachea should have been concave. Now it is convex. So there has to be something underlying, and we can start suspecting them, and we can demonstrating a early bone destruction. And this is the C1, C2 disease. This is the same X-ray which I was just talking. Here, if we do not get an MRI here and diagnose it, then what is going to happen in few weeks down the line, kyphosis will appear, obliteration of disc space will appear, and this shadow has increased to longer extent. So we should start investigating on our definition of a presumptive case and investigate them. C1, C2 area, the same thing, destruction of underlying bone. Similarly, so if we get an MRI, this is the X-ray which I had shown, and you could see contiguous vertebral body involvement, preserved relative preservation of disc spaces, subligamentous extension, low signal in T1, bright in T2, large pre and paravertebral. This is a large prevertebral abscesses. This is a paravertebral shadow which is septate paravertebral shadow, septate paravertebral shadow, and epidural involvement. You could see that this has broken into the epidural space and intraosseous abscess. So with this constellation of these findings, in 90% instances on MRI, we are able to make a diagnosis of tuberculosis spine. We can absolutely sure we can treat these patients on these findings by ATT. I'll give you another example. Symptomatic patients, reduced disc spaces, although not a classical X-ray finding, we cannot label it on X-rays as tubercular lesion. But look at MRI, two vertebral disease, relative preservation of disc spaces. See the septate low signal abscesses which are bright in T2 weighted image, and this is on MRI, this is a tuberculous lesion. And in this patient, even diagnosis was ascertained by a tissue biopsy. Now here, in comparison to the X-ray picture, MRI picture I have shown, if one gets this kind of a heterogeneous signal in multiple vertebral body, then our differential diagnosis besides tuberculosis is myeloma and lymphoma, and tissue diagnosis is a must in all such cases. No patient should be treated on MRI because it is unethical and wrong to treat these patients by tuberculosis on empiric basis, because this differential diagnosis has a sinister conditions. Now, not only that, MRI could differentiate a liquid compression from a dry compression. And we should be able to understand the difference in these two types of compression. And here the compression is caused by a dry tissue like disc, while here it was a liquid pus. One can even know the site of involvement. It is the body involved or it's the posterior complex involved, and what is the quantum of compression. And here you could see it is the body besides the posterior complex is disease, besides the posterior complex of the vertebral body is disease. Now this is a potentially unstable situation. Spine needs to be stabilized here. So the message is we must make a diagnosis by all being. Diagnosis has to be ascertained either by imaging or by a tissue diagnosis. Now tissue may be open or percutaneous, and any tissue procured should be submitted for microbiological and molecular diagnosis and histological diagnosis. Any tissue, pus, bony tissue, soft tissue must be sent. If you have enough tissue, intraoperative tissue, then every piece type of tissue must be sent, because it is the surgeon's responsibility to give a biopsy. It is not the sister's responsibility to choose the tissue. It is the operating surgeon, chief surgeon, has to ensure that proper tissue is being given, submitted for investigations. And tissue may be obtained by surgical debridement, aspiration, percutaneous by any method. Adequate volume of tissue should be sent. Leak-proof, in a leak-proof translucent container surrounded by absorbent material. It should be shock resistant outer package, and no preservative should be given. It just should be in a plain water. Sample should be immediately transported to laboratory and be processed as soon as possible. However, if the laboratory is far and if you are not able to send immediately, please keep these samples in 2 to 6 degrees Celsius and should not be kept more than 7 days. Tissue must be processed properly and safe working practices to be used to avoid contamination by bacteria other than tubercular bacilli. The yield of tissue diagnosis depends on surgeon. Surgeon has to take responsibility to have a better yield. Now, I would tell all my postgraduate, please remember this picture. You will get this picture in all my publications. This picture is a hierarchy of diagnosis in tuberculosis. And you could see the diagnostic surety increases from below to above. Demonstrating an organism is the gold standard. But we know paucibacillary, the chances of demonstrating an organism varies with between 30 to 50% depend on the quality of laboratory. Now, then molecular method comes after the culture in the hierarchy. Although I have written not known, but now it is no longer not known. There is enough work has been done on this way. Just I'm going to tell a few slides afterwards. AFB smear comes below. Why it comes below? Because the chances of demonstrating AFB is lesser than the culture. Histological diagnosis, 60 to 90%. 60% is consistent, where caseating granuloma is demonstrated. Where epithelioid cell and other features are demonstrated, not classical tubercular are demonstrated, then they are suggestive. So they are giving this suggested diagnosis based on history being given to by us to the histopathologist. So these are the individual test diagnostic accuracy. While we know that radiological and imaging, clinical suspicion, and therapeutic response are very low, so we should not be treating patients on ATD by these bottom three. We should ascertain the diagnosis by all above methods. Now, so then, since the credible data was not there, so a study was undertaken, and now that is published in Indian Journal of Orthopedics, where CBNet and line probe assay, molecular method, liquid culture, AFB smear, histology in diagnosis of osteoarticular tuberculosis was studied, and we recently published that article. Now, in that, there were 65 fresh TB cases and 12 suspected drug resistance cases. AFB smear demonstration in this best of the lab, best of the tissue given was 47% in a fresh cases, which the moment culture was added to the smear, it became 69% in our hand. When histology was added, we were able to ascertain diagnosis in 93% samples. And when micromolecular methods were added, we were able to demonstrate, make diagnosis in 100% instances. So what is the message? If you have taken the tissue, submit it for all to have a better diagnostic yield. Then only you will be able to confidently treat these patients. Not that you just give for smear and wait for the result, or give for culture only, or give for histology only, because we must know that in a paucibacillary lesion, we must understand the limitation of each modality. So keeping all tests in tandem will make diagnosis and diagnostic accuracy becomes 100%. And the same thing happened in a suspected drug resistance, where diagnostic yield on AFB smear was only 25%, culture was only 25%, but we were demonstrating tuberculosis by histology in remaining and up to 83%. But when molecular test added, we were able to ascertain diagnosis of drug resistance in 100% instances. So diagnostic accuracy of molecular method alone is 90%. However, when it is put to all other tests, then it becomes 100%. But then the advantage of molecular method is that we were able to demonstrate primary drug resistance, one drug or more, by gene experts or by LPA, gene expert for rifampicin and LPA for rifampicin and INH. One drug or more, we could demonstrate drug resistance, primary drug resistance in 5 to 6% instances. While in presumptive drug resistance cases, we know that in 75% instances, culture was negative. So it was only molecular method which helped us in demonstrating drug resistance. Then we took another study which is still unpublished, where we took 10 drug resistance in 60 presumptive spinal tuberculosis cases, which include 52 primary spinal TB cases. So again, diagnostic accuracy was the same, that you have to get all patients together to make a diagnosis in all cases. However, the surprising part was that this time primary drug resistance rose to 25%, and that was astonishing. This work we still have not published. So why I'm giving this message is because if you have taken the trouble of procuring the tissue, then submit for all. As best as possible diagnosis one should be able to get. And I'll give you one example. Cervical spine tuberculosis, very easy to aspirate from putting a needle between the trachea and the carotid. And this pus was aspirated, and this demonstrated low level INH resistance. So in this patient would require a high dose of INH. Now here again, when this patient was operated because of deformity, on DST, no drug resistance. Smear for AFB positive, liquid culture negative, and histology consistent for TB. So out of 4, we were able to, because the tissue was sent for all, we were able to ascertain the diagnosis. Very important patients, lumbosacral tuberculosis, first time presented. And when we did CT guided biopsy, we could demonstrate drug resistance for rifampicin and INH high level. Smear for AFB was negative. Liquid culture was negative. However, cytology was consistent for tuberculosis. So had we not submitted for all, we would not have ascertained the diagnosis. And with the culture sensitivity, we were able to demonstrate the resistance as well. So the message is we must have a robust diagnosis for all cases of tuberculosis, whether it is spinal or it is limb, whether it is by imaging or it is by tissue. But diagnosis there must be a very positive diagnosis, and a confirmed, ascertained diagnosis must be ascertained. And we must aim to make a diagnosis before classical deformity for the peripheral joint comes and a deformity for the spine comes. So we should be able to diagnose in inflammatory stage and before deformity and neural complication for the spine concerned, so that we can start treating. Now, as far as treatment is concerned, mainstay of treatment is a prolonged continuous multi-drug ATT. Excuse me. And there will be indication of surgery. Surgery will be indicated. So we have to take type of surgery, surgery in para and quadriplegia, in children, granuloma, and late onset paraplegia, which in these subheads, we will be talking about the surgery. But these all require, these all issue needs individualized approach, needs to discuss. Now, when the ATT started, British Medical Research Council, they compare 750 patients in a different part of the world between 2 drugs or 3 ATT, bed rest or ambulant chemotherapy, radical clearance or conservative, and radical clearance or debridement. So these kind of studies were done, and there was no difference in the healing. So this study concluded quite confidently that it is a medical disease, and surgery is to be done for complications. Now, we will talk drug therapy in these 5 subheads: drugs and volume, intermittent or daily, duration and point of treatment in children, and failure of drug therapy or suspected drug resistance. We know it is a multi-drug ATT, which is essential. Why it is multi-drug? Because in a growth of mycobacterium, there are the organisms which are dividing at a different pace. There are extracellular rapidly dividing organisms which are being affected by INH, streptomycin, and ethambutol. Extracellular, slowly intermittently dividing bacteria, they are acted upon by rifampicin, and intercellular, intermittently dividing bacteria acted upon by paracetamol. And that is why we have to have drugs acting against all kinds of bacteria. That is why multi-drug ATT is given. There will be some dormant bacilli which will not grow, which will lie in the body, which will no drug will act, and they can and we are not treating dormant bacteria, and they can lie dormant for extended period and can get activated later in life, causing relapses. So drug combination, rifampicin, INH, ethambutol, paracetamol, covering all kind of dividing bacteria, and so intensive phase for 2 months, followed by rifampicin, INH, and ethambutol in a maintenance phase. I think we all, you can all recall, it used to be rifampicin and INH, but there is a good amount of resistance against rifampicin has been demonstrated, mainly from Gujarat, but I think now a lot of data is coming even from Delhi, we and someone from Mumbai also. A lot of INH resistance has been demonstrated, and that is why the program says that it should be rifampicin, INH, ethambutol for full maintenance phase. Now, should we give every day? Should we give intermittent? I think you all will remember then that the DOT strategy was intermittent regimen, because it works on the principle of lag effect. Why it was given a lag? That what is the lag effect? When bacteria is put under the suppression by certain concentration of drug in the blood, then bacteria goes under suppression, and then the drug is withdrawn. Bacteria, mycobacterium remain suppressed for 24 hours to 48 hours. And then you give another dose of drugs. So bacteria will not be replicating. And that's how intermittent protocols were scientific. But then that is why 3 times per week a protocol came. And the whole objective was so that we can improve compliance and could be given supervised also. And that is why the DOT, directly observed treatment strategy, DOT strategy came up. But the problem was that if one misses the 1 dose out of the 3, then the risk of are serious consequences, because then it is a suboptimal treatment and the risk of emergence of drug resistance. And that is why now there is no confusion, no more intermittent by all programs. Whether it is Government of India, whether it is WHO, only daily doses ATP is to be given. Now, third issue is how long. There are a lot of schools of thought: 6 short months, 6 months, 9 months, 12 months, 18 months. And I think for pulmonary TB, it is practically now it's being resolved 6 to 9 months. So the question comes, when it works for pulmonary, then why not for bone? It is a paucibacillary disease, and that is why the world over opinion is divided between 6, 9, 12 months. I think we need to understand one thing, that for pulmonary, if there is a sputum conversion has taken place at 2 to 3 months, then another 4 months ATT is good enough. And they are able to document sputum conversion by repeated sputum tests. But for us to demonstrate a healed status, improved status, conversion of lesion into a bacteriologically sterile is not possible. And that is why all studies, our healed status used to be completion of regimen, whatever regimen is been in practice by pulmonary team, with no recurrence for 2 years. And certainly these follow-up studies, they are very few in number, but yes, there are some. So that is why the opinion is divided into different 6 months, 9 months, 12 months for bone TB as well. When we were making these guidelines, we made the search of the literature, and the optimum duration of treatment was an uncertain situation, because there was a lack of consensus about what constitute healed status in the literature. So to define the endpoints, we took contrast MRI as the endpoint, and we did this study, and we demonstrated that some of these patients at 8 months, they are able to demonstrate healed status on MRI, while in others not at 8 months, in 12 months. So what we found that 35% patients achieved healed status at the end of 8 months, 60% achieved at the 12 months, and 90% at 18 months. And then we just concluded only that it is unscientific to stop ATD by fixed time schedule. We need to evaluate these lesions till they attain the healed status. So issue remains still unresolved. And what we observed that yes, there is a large number of patients where MRI continue to show a persistent bone edema. Should this persistent bone edema be taken? This is a enhancement here in this area. Should this be taken as a continued disease activity or a inflammation of a healing? So to resolve that, we did a PET scan, and we did again study where we took these patients' healed status on a evaluated on contrast MRI and PET scan. And again, what we found that PET was showed healed lesion in 28 of 28 100% instances, while in those patients only 50% MRI demonstrated healed status. So, and particularly stainless steel implant, PET could be the only modality to demonstrate healing. But we believe that's the only conclusion which we came out again of this study, that treat till healed status is demonstrated. But yes, this issue is open, and I'm sure that a lot of studies are coming up, and I think we need to take up resolve this issue with some more studies to define as of now what is the endpoint and what should be the regimen. But what we are following is 12 months and then continue to evaluate lesion. And I'll give you this small example. 17-year female, no neural deficit. You could see paravertebral shadow. This is the MRI diagnosis. Treatment ATD was given, and radiologically, this abscess shadow has vanished. On MRI also it showed, but continued to show edema, and we extended a bit, but at 12 months, PET scan shows no metabolically active disease in dorsal spine or anywhere in the body. While in this cervical spine tuberculosis, classical X-ray of and classical MRI finding of a cervical spine tuberculosis, at 9 months, MRI-based, X-ray-based healing is demonstrated. MRI-based healing is also demonstrated, but there was some persistent activity, and which at this time, because she had a tumor also in the body, so PET scan was done for tumor, and at 10 months, there was no activity, and we stopped ATD. So it means there will be a variable duration of ATD intake. This is another example I just showed when I was talking about MRI, and this is the lesion on X-rays and MRI diagnosis. And this patient CT guided aspiration was done. Gene expert line probe demonstrated sensitive or rifampicin and INH. Smear was positive, liquid culture positive, and sensitive to first line drug. So our diagnosis was ascertained, and we treated by non-operative 2 months, 4 drugs, RHE for 10 months after diagnosis. Overall, he was on 15 months ATD. And you could see at 15 months, it showed some improvement, but it has not complete radiological healing. And you could see on MRI, there was an intraosseous abscess, which you could see the intraosseous lesion, which on contrast enhancement was an enhancing intraosseous abscesses. So we were in a dilemma. Are these sterile abscess, or are these, should we continue ATD? Should we stop treating as a sterile? So we got a CT guided biopsy again, and histology showed granuloma again. Although gene expert was sensitive to arsen and INH, but gene expert molecular method are not to be relied upon in a follow-up patients. But then presence of granuloma in histology was good enough evidence of an active disease as yet. So our conclusion, and even in the guidelines, it is 4 drugs for 2 months, 3 drugs for 10 months, daily doses, close monitoring for neural deficit. Some patient may require surgical intervention. You have to take them for intervention as for indication. Total treatment duration 12 months, extendable to 18 months on case-to-case basis. Now coming to ATT in children, I think children are not miniature adult. These ATT is to be, these are the drug doses, 10 milligram per kg for INH, rifampicin 15 milligram, pyrazinamide 35 and ethambutol 20. And as children approaches to a body weight by 25 kg, adult doses can be used. And these are the weight bands. The child weight has to be taken, and these are the combinations where the rifampicin, INH, ethambutol, pyrazinamide comes in different volumes, and that's how we can monitor, modify the regimen as per the weight band. And let me tell you, with every visit, the child's weight should be taken, and ATT should be revised, because these children gain weight immediately after put on ATT. And this is a proof that only by ATT lesion resolved, and you could see this compression, intraspinal compression, has completely resolved, and this CSF has appeared. So this is a proof that some of these patients may just show a resolving lesions on ATT alone. However, we need surgery. Knowing fully the drug therapy is mainstay, surgical indication may be for cord compression, or maybe for instability, impending neurological deficit in a global disease where anterior and posterior part of the vertebral body is diseased, or in a long segment disease where after decompression, long graft is to be placed, or when you are contemplating a deformity correction, or maybe in children sometime, or maybe a presumptive drug resistance. So we do surgery for these many indications in spinal tuberculosis or late onset paraplegia or late onset paraplegia. Now, how the surgical treatment has evolved, this I talked about evolution of a diagnosis and drug treatment. How the surgical, as I said, Hodgson's put anterior transthoracic decompression, and he believed that lesion to be radically excised until healthy bleeding cancellous bone with suitable surface for reception of graft is achieved. And he believed in interposal graft. And the issues at that time were intensive care facilities and patients, because these spinal TB patients, they have a poor GC and they might have a coexistence pulmonary TB. So after a radical resection, such a huge gap needs to be bridged by bone graft, and graft is weak on the day it has been put in, and then hence graft related complications, graft slippage, graft breakage, and increased kyphus were reported. While another belief was that we must debride only, remove pus, caseous tissue, and sequestra, and remove unaffected or viable bone only to provide adequate access to the focus and to decompress the spinal canal. And that's how just decompress the spinal canal, and this bone should be there so that a relatively stable spine is left and graft-related complications can be avoided. Because we believe that bone in tuberculous lesion are infiltrated, infarcted. These bone recover on ATT, while necrotic and separated bone, they require removal, or a disc tissue require removal. And that is why debridement is good enough, not the radical excision like a tumor. Now, even surgical approaches has evolved. Cervical spine, we do by anterior approaches, lumbar spine, anterior retroperitoneal approach, but then now for lumbar spine, all posterior approach has come. Dorsal spine has evolved from transthoracic, transpleural to extrapleural, anterolateral, and now only posterior approaches. And these are the approaches for cervical spine, and even for tubercular lesion, these lesions, they are debrided, decompressed by this approach. While for lumbar, if we were going anteriorly, then retroperitoneal approach were practiced. But for a dorsal spine, transthoracic, transpleural used to be a very common, where chest used to be opened and pleural adhesions used to be removed, lung used to be collapsed by double lumen tubes, and lesion used to be debrided. And this is what is the debridement of the lesion. While in extrapleural, the posterior part of the ribs, as per the label of disease, were removed. We remained extrapleural and reached anterior to the vertebral body and decompressed the spinal canal and debrided the lesion. So these are extrapleural anterolateral decompression. So comparing the outcome, and while doing this, we found that since the instrumentation and other issues, we modified this incision from this C incisions to a T-shaped incision, and that is how anterolateral decompression is done. The spatula is on other side of the vertebral body. One can decompress the canal here, and that is how decompress the spinal canal here. And this is the CT picture after decompression of the spinal canal by extrapleural. We did randomized controlled trial of a transthoracic and extrapleural, and we found a similar decompression is done by transthoracic as well as extrapleural. So we abandoned the transthoracic. Now with all posterior approach coming up and instrumentation is coming up, transthoracic is never being practiced. Only all posterior or extrapleural anterolateral decompression is practiced. And with this extrapleural and anterolateral, I could demonstrate a deformity correction as well. This is another example of deformity correction by extrapleural anterolateral, and this is simultaneous anterior decompression and posterior instrumentation of tubercular spine using anterolateral extrapleural approach. One could see here, this is the posterior instrumentation, and this is the anterior lesion, spatula present on the opposite side. We use this approach to dorsal lumbar junction as well, and that's how the incision we described and the steps we described, and that is how this decompression and instrumented stabilization can be done. Now with all posterior, where what is a must? A pedicle screw fixation, because what we are doing is in all posterior, we are excising the posterior column to reach through the pedicle anteriorly in the anterior disease area. So in an anterior disease, we are excising the posterior column, spine becomes grossly unstable. And that is why pedicle screw fixation is a must step. So you have to do pedicle screw fixation above and below first, and then the decompression of the lesion. And this is little more, making it more unstable in a long segment disease. So that is why, but then all posterior is one of the most commonly done nowadays for limited disease decompression or a deformity correction. Now, I'll give you some example. This is the deformity correction, which we did with the extrapleural anterolateral approach. And you could see here, the deformity is fully corrected, anterior graft is well placed. Now then coming to TB spine with paraplegia. Well, again here, surgery for all versus surgery for few prognosticators is an issue. Whether should we go with the middle path regimen or should we do decompression for all? I think middle path regimen came just because some of these patients were poor in general conditions, and while waiting for their fitness for surgery, some of them showed neural recovery, and that is why and in Tully's series it was 38% patient showed neural recovery. So that is why the middle path regimen came. We did 60 cases with or without paraplegia and prospectively evaluated on treatment by MRI. And what we observed that some of these patients without neural deficit even had a 76% canal encroachment. So it is not the canal encroachment alone, but more other than other factor, which is the cause of neural deficit. So if there is no neural deficit, only canal encroachment on MRI, and that too by liquid compression, need not to do a surgery. Similarly, a liquid compression, which is low signal in T1, bright in T2, and you could see intraspinal compression. And if spine is stable, these are likely to show neural improvement. And I have given you one example that this compression has completely resolved. While mixed extradural collection of a dry lesion, where there is a heterogeneous signal, then these require surgery, early surgery, because here we know that compression is by disc bony sequestra. So all those patients which has a mixed extradural collection should be undertaken for surgical decompression very early. Now, spinal cord in some of these patients have undergone only edema and myelitis. So edema and myelitis is found compatible with neural recovery, while myelomalacia with a poor neural recovery. So all those patients with has a dry lesions with myelomalacia should be immediately taken up for surgery. So what are the patients who respond well, may respond well on active disease? If There is a predominantly fluid collection, relatively preserved cord size, cord edema and myelitis, and there is no evidence of instability like a global disease. Then these are the patients which, according to Tuli, 38% patients on a 6 weeks or 4 weeks ATT have recovered. Probably we can at day one identify these patients. Should we instrument in spinal TB? Because it is a common saying that no metal in infection because biofilm is formed. But the work of Oga et al. Has cleared this issue that biofilm formed in tuberculosis is very thin. And we did a meta-analysis of the article published till 2005. And we found that there is no consensus when instrumentation is to be done and what are the types of instrumentation to be done. It was based on the individual authors. So we defined the indication of instrumented stabilization. And according to, they are pan-vertebral lesion when the body is diseased and posterior complex is diseased. And if we do not identify before and stabilize it, then that's how the translation of the proximal spine over distal spine will occur. And this neural deficit, compression onto the spinal cord, because it is mechanical as well as catastrophic, accidental, the neural deficit will be may not recover, and in spite of decompression and instrumented stabilization. So all pan-vertebral lesions need to be identified, and they need to be the instrumented stabilization need to be done because they are grossly unstable spine. Or a long segment disease is again a grossly unstable spine. Or after a post-debridement, we find that the graft interposed is 4 centimeter or 5 centimeter or more, or 2 vertebral body heights. Then the posterior instrumentation should be done to support the graft. Or you are contemplating a correction of spinal deformity, kyphotic deformity, or TB of junctional area. Then these are the indication of instrumentation. Now, what is the type of instrumentation? Pedicle screw, hard shell segmental sublamellar stabilization, or a plate fixation. Well, to my mind, all works well if correct principle is used. Here, in a child, all posterior instrumented stabilization by pedicle screw was done. Here, in a dorsal spine, hard shell instrumentation was done. And here we planned off a pedicle screw fixation, but while putting a pedicle screw in the above vertebral body, pus started coming out from these 2 vertebral body. And that is why we thought that pedicle screw is going to be loose. So we combined the pedicle screw and the hard shell. So any method, any gadgets will work if it is used judiciously. In this cervical spine, we did use the lateral mass, and then anterior lesion was just grafted. We could have put a plate as well. So it all depends how the correct principle is used. I'll give you this example. You could see such a long segment disease. You could see such a long disease here, disease here, disease here, and you could see here on an MRI. And you could see on CT, destruction here, destruction here. So we thought that probably there are all posterior segment are good, and let's decompress this area and let's instrument by a long segment hard shell fixation, so that few segment, if we do a pedicle screw, then we might have gone above, further up. So we use this segment taking purchase against the healthy posterior segment, and we got the desired outcome. Again, skip lesion, both level compression, neural deficit compatible here. And you could see here the lesion 1, 2, 3, 4, 5 vertebral body is disease. So, well, again, we took a purchase by the hard shell from the proximal segment, middle part, and the distal. And since it was a stainless steel hard shell, healing was ascertained by PET scan. So that's how we treated this patient. Now, in a 7-year-old child, C1, C2 disease, treated by ATT, and it is very uncommon when you get a stress film in these patients, they continue to have a C1, C2 instability. So we just did the C1, C2 posterior fusion by Galli's wire, and we achieved the desired stable spine. Now coming to spinal deformity, we know that kyphotic deformity is a problem. in spinal tuberculosis. And we know that if kyphotic deformity is left beyond 60 degrees, then they are going to come back with the late onset paraplegia, which is more difficult to treat. And hence spinal deformity need to be corrected. By identification, all issues of a deformity, its identification, natural history of disease, deformity correction principle, and deformity in children. These are all big issues. They require a lot of reading, and they are to be addressed by all those people who are well versed in correction and treatment of spinal deformity. But from a student point of view, 60-degree or more spinal deformity, there are risk of late onset paraplegia. Deformity may progress while treating on treatment in adult as well as in children. Initial vertebral body height loss is a predictor of final kyphosis at the start of treatment. So anyone with a 1.5 vertebral body height is likely to end up in a 60-degree kyphosis once disease heals. And we must realize that deformity correction in active disease is easier and has less complication. That is why we need to identify which deformity need to be corrected in active stage of disease. And when we have decided how to do it, that becomes an issue. And this is the line diagram of a tubercular lesion with a kyphotic deformity. There is a retropulsion. If we correct without opening the disease, then this retropulsed tissue is going to make a pressure onto the spinal cord, and patient is going to become an increase in paraplegia. And that is why what you require is an anterior corpectomy. Remove the disease focus completely. If you correct the spinal kyphotic deformity without opening the disease, then this vertebral column is going to lengthen. And that is why the posterior column shortening has to be done. And when you have done anterior corpectomy, posterior column shortening, spine is unstable, instrumented stabilization, anterior gap grafting, and posterior fusion is to be done. These are the steps to be done in any deformity correction. And now the strategies for every child, every adult, you have to plan. And I'll just give you some example here. The pedicle system was used. And in this 8 kg child, we just couldn't do anything other than this. And even here, there was a concomitant spina bifida. Now, this is a long-standing kyphotic deformity presented with a huge abscess as well. And you could see a 5 vertebral body disease. So what we did, we put him on a cephalocaudal traction so that this deformity opened up a bit. You could see here. And later on, all posterior, pedicle screw fixation, posterior column shortening, and deformity correction was done. And this is another example of deformity correction. Now, the next issue is a drug resistance. Sir, we'll take another 10 minutes if you, or should I stop?
No, sir, you can proceed, sir. Please, okay. Sir, you can.
So drug resistance.
Because this is most important thing, drug resistance, the boys must know as well.
Now, drug resistance in spinal TB, it is known, well documented for pulmonary tuberculosis. As you know, for any bacteria, when the new drugs comes, immediately you start getting drug resistance against that drug. So same is true for mycobacterium as well. If you expose mycobacterium to certain drugs, there is an inherent population 1:10⁶ for one drug or some other drug. There are multiple. So one of the organism is drug resistant, and if the sensitive organism are removed, then those resistant organism can have a colony of resistant organism, a resistant disease by resistant organism. But more important than that, besides the genetic mutation, if we treat these patients by suboptimal drug doses, where the drug doses are less, or whether it is less number of days missing of the regimen, or less volume drugs being used, then these susceptible organism will die out and the resistant organism will multiply. And some of these organisms, they mutate to develop resistance against the drug. So the most common cause besides the genetic mutation is the suboptimal ATT regimen. So it is a man-made problem. And that is why we have to understand the drug resistance very well, that treating at first instance by proper drug combinations and regimen is the key to prevent the drug resistance. Now, after this information, I will move on that how the diagnosis and treatment of a suspected and drug resistance is difficult in comparison to pulmonary. See, pulmonary is very simple. You keep on getting a sputum, and if sputum does not convert after 4 months of ATD, you suspect a drug resistant, and you put for all method to ascertain the drug resistance by putting them on culture and all that. We cannot in such a country put every patient to the culture because our facilities are limited. So we need to identify which patients is a suspected presumptive drug resistance in spinal TB and how we should proceed on. So with this background, we know that for osteoarticular TB, the reports started coming out around 1998. Our biggest issue is which is the patient where we need to suspect drug resistance and how to establish drug resistance, and if established, how to treat. Now, I'll give you one example. This is a patient, and you could see all MRI finding, and you have and the ATT was started, and 9 months down the line, the same lesion, same MRI picture, and in fact, it is not the same. If you look at the mid-sagittal, one of the more vertebral body has become diseased. So this is what something is wrong. Drugs are not acting, and this is what is a suspected drug resistance. So first of all, we need to define the criteria. So in one of the study, we defined those criteria. What is a suspected drug resistance? Now, when the lesion is not healing, our concern is our diagnosis correct? Are we treating tuberculosis or any other granulomatous lesion wrongly as tuberculosis? Or if our diagnosis is right, then is it paradoxical reaction or drug resistance? These are the question of clinician. And that is why we have addressed this part, that there should be a very good diagnosis at the start of treatment, any case of TB. However, after a correct diagnosis, then these are the only two things which comes to our mind. So what is a paradoxical reaction? If there is a clinical deterioration of TB lesion or development of new lesion in a patient who has initially improved on ATD for 1 month or so, and this occurs during the early phase of treatment in the first three months, this is paradoxical reaction, and here you don't have to do anything except to reassure. While suspected drug resistance patient failed to improve from or deteriorate at the start of ATD. And there is no improvement until an effective second-line regimen is started. So we need to differentiate paradoxical from suspected drug resistance. Now, if you have suspected a drug resistance on the criteria which we have defined, that a patient who failed to respond clinical and imaging 6 months and more, or develops a newer lesion, or a new abscess or new sinus comes, or a post-operative patient, a wound dehiscence occurs, then it is a failure of treatment from day one. And then in such cases, our line of action, we need to ascertain the diagnosis first by histology, smear, and genotypic analysis. DST culture to demonstrate the resistant organism, and even my gene expert and line probe assay. Gene expert diagnosis and rifampicin resistance, and line probe rifampicin and INH resistance. And we must put the tissue to, once we have procured the tissue, to do all that to two national accredited laboratories. It is a very good habit to giving tissue to 2 laboratories. Now, by this, we should be able to ascertain the diagnosis. Now, what are the different definitions? If one is able to demonstrate resistance to one of the 5 first-line drugs, then it is called monoresistance. If polyresistance, 2 or more first-line drug resistance, MDR, resistance to rifampicin and INH, and XTR, resistance to rifampicin, INH, fluoroquinolone, and any injectable other than streptomycin. So these are the various definitions, and according to demonstrable drug resistance, we are able to treatment. We should treatment. So now question comes, in this article we have demonstrated what is the presumptive drug resistance cases. Now when we have put to investigation, we have to understand the nature of bone and joint, because it is a paucibacillary. So in some of these patients, we will be able to prove drug resistance by histology, tuberculosis, by culture or molecular method. We will be able to demonstrate drug resistance and prove the, once the drug resistance is proven, it is to be treated as a proven drug resistance based on the demonstrated drug resistance. Now, there will be a situation where histologically we are able to demonstrate tuberculosis, but culture may show no growth and molecular method may be indeterminate in some percentage. In that case, we have to treat them as a clinical drug resistance as MDR. Now, what are the principles of chemotherapy? These second-line drugs are less potent, more toxic and expensive. They are used in higher number, often 4 to 7 at a time, and may require hospitalization. The principle is never add one drug to failing regimen. It is a very wrong practice that, okay, your response is not proper, let's add fluoroquinolone. No, I think that's wrong. Either treat with the standard regimen, or else once you are able to prove it, then a proper drug resistant regimen should be used, never a single drug to be added. Preferably 5, but at least 4, at least new drugs should be added. Single dose therapy should be given, no intermittent therapy. No drug should be kept as reserved. If you have achieved the drug sensitivity, then best drug combination you should treat. It should be ensured that patient has taken the ATT, and surgical treatment as an adjunct to be used, because it reduces the bacterial load. And patient should be counseled, most important, not to stop treatment even if discomfort present. And these are the various regimen. This is the principle of regimen. Intensive phase, 6 drugs for 6 months, which should include 1 aminoglycoside, kanamycin, amikacin, or capreomycin, any fluoroquinolone, any thalidomide, any 2 or more of the following: pyrazinamide, ethambutol, PAS, or cycloserine. And in maintenance, stop kanamycin and then continue 3 most active and best tolerated drug. I would always recommend, while treating the drug resistance cases, always take a pulmonologist with you. And these are the various regimen which have been suggested by RNTCP and WHO. And you could see, if drug susceptibility is not available, what I said is a clinical drug resistance, then these are the combinations. If resistance to rifampicin and INH, these are the drug combination. Resistance to all essential drugs. And now there are many more regimen have come because there are some new drugs have been added. But prevention of drug resistance is the key. Ensure drug compliance at first instance and monitor drug response closely. And this is an article on drug resistant spinal tuberculosis, which is published in Indian Journal of Orthopedics, and one can read. Never add a single drug to failing regimen, and good nutrition status should be maintained, and that's how we can prevent the development of drug resistance. Now, this is one example. You could see this patient and classical MRI finding, and here 8 months ATT, again the same lesion, same abscess. So, and you could see 8 months, it is the same disease. So what we did, anterolateral decompression, and pus culture was negative, bactec was negative, AFB smear was negative, TB PCR histopositive. So diagnosis was correct. And at that time, gene expert and LPA was not available to us. So we treated as a clinical drug resistance. Second line ATT was started. Well, in the present time, we would have submitted for gene expert and LPA as well. So there would have been a chance that we could have demonstrated the drug resistance. But then we treated as a clinical drug resistance. And you could see here at 18 months ATT, radiological healing, and you could see MRI healing. And you could see here the in T1 weighted image, the fatty replacement of bone has taken place. So it's a very good evidence of an healed disease. And you could see on MRI, and we got a PET also done at that time, no evidence of metabolically active disease in D910. So in 15 months time on a good second line ATT patient has shown a healing. Now this is the example which will tell us many more lessons. This patient reported 2014 backache, fever with constitutional symptom. At some hospital was diagnosed TB spine D10, D11, started category, and that was May 2009. This was some hospital. And this was radiologically diagnosed, correctly treated by the then regimen, and shows radiologically healed lesion. Now here, 2012, 14 months down the line, patient again came back to the same hospital. They this time got an MRI because MRI was available, and that shows a new lesion, L3. And again, they started 4 drugs plus streptomycin as category 2. And after 18 months, ATT was stopped correctly, but patient was continued symptomatic. So the newer MRI shows a sauce sepsis, aspirated, again pus, again somebody started all 4 drugs. But then in 2014, someone thought that probably because our knowledge about drug resistance was not that good, so he started cycloserine and moxifloxacin. And the logic was not very clear because probably our knowledge was not good at that time about the drug resistance. And MRI was performed in 2014 by him only, shows a reduction in the size of abscess. So it means that was responding well, but then he stopped for no reason, and rifampicin INH continued. Now, when he stopped all those drugs, so patient continued to remain symptomatic, patient continued to move from one hospital to other, and CT guided came to us, CT guided biopsy was done, and smear was negative, culture was no growth, but biopsy was, histology was suggestive of tuberculosis. So we ascertained tuberculosis, but in CT guided, only few drop of pus could be obtained. So we couldn't make a diagnosis. Now, looking at this kind of a presentation, looking at MDR, by the time patient reported to us, so we went in for anterior debridement of the lesion, and this lesion has a thick mass of thick mass of tissue with peripheral rim of pus and demonstrated drug resistance. A clear drug resistance was demonstrated, and patient achieved a healed status now. So that is how we evolved onto the drug resistant tuberculosis. I think I'll take few minutes just to tell these children what is the difference in a childhood disease from an adult disease. I think in children, it is different than adult because these are cartilaginous disease, destruction is more rapid, and severe deformity comes in rapidly. And more important than that, deformity progresses with growth. And you could see here that this child, when he came to us, was carrying this X-ray. This X-ray was just 3 months old. And in 3 months, it has progressed from this to this stage. Had he come at this stage, then we would have treated, and with the lesser deformity, now it is a big problem. So in children, progression of deformity is very rapid. Now this deformity progresses with growth. In children, even after stoppage of ATT, some of the deformity progresses with growth as this has progressed. This was an old patient when in 91 or 92, where in spite of positive fusion, this has progressed. While here, some of the lesions may progress, some of the lesion may not progress. So we need to monitor these patients for a progression of deformity by growth, by just a normal growth till maturity. And in that, the criteria given by Rajashekhan should be spine at risk, should be seen at the early part of disease and identify a progressive kyphosis, because we know that it's about 30% or 40%, they progress, others do not. So we need to do something to identify those progressive spinal deformity, to correct them before they become a severe deformity. And now here you could see severe deformity progressed from a childhood disease. And here, when they have come at this stage, if we put all those criteria and we treat them well, we correct this spinal deformity, then this kind of progression could be avoided. And this is one example. This child mother was telling that child, when lie down, there is no deformity. When child gets up, there is the child buckle, the spine buckles over, probably a pseudo-arthrotic in a spongy disc spine has occurred. And probably this anterior fusion has to be achieved to prevent progression of deformity. And these deformity need to be surgically corrected. And all strategies of correction of deformity should be used in all these children. Otherwise, some of them, they come back with a severe deformity. Now, this child presented to us, 14-year-old child, with such a severe deformity, a progressive deformity, and father was telling that this deformity has progressed in last 6 months itself, which even father was able to. And this child was carrying all these X-rays and MRI, where I'm sure had this all been treated well at this stage with the deformity correction, because here you could see a global disease. Here you could see body disease and posterior complex disease, body disease and posterior complex disease. I think this deformity should have been corrected in the active stage of disease. And now it is a big problem because it is a healed spine and a progressive kyphosis. And there are more chances of developing a late onset paraplegia. Now, a word about late onset paraplegia. A paraplegia with a healed disease is the other term of late onset paraplegia, where if there is no active, this paraplegia comes when a patient initially treated for TB spine with a residual kyphotic deformity comes back with appearance of neural signs, neural deficit, 10 to 15 years after. And that is classically described as late onset paraplegia. Reactivation of disease is the cause of paraplegia in 30 to 40% instances. It was very difficult to diagnose and treat in pre-MRI period, but now it is because spinal cord undergo atrophy, certain changes in these spinal cord. But the other causes of paraplegia is a severe neural deficit as a result of spinal stenosis above the healed segment, kyphosis. And this has been now published in quite a few studies. Ossification of ligamentum flavum distal through the lesion has, after a healed tubercular kyphosis, was also being reported. So these are the various causes of late onset paraplegia. So better prevent development of paraplegia with healed disease by correcting kyphosis and active disease. Do not allow it to heal with severe residual kyphosis more than 60 degree. However, if report as late onset paraplegia, identify the cause. By an MRI, if there is a reactivation of tuberculosis, then treat them as a reactivation. Probably a patient has a better chance of recovery. Otherwise, if there is only cord stretching at internal salient, decompression still have to be done of removal of internal salient to prevent progression of neural deficit. And instability and ossification of ligamentum flavum, these are the other causes which need to be addressed. And this is line diagram where you could see if there is no activation, this internal salient, the spinal cord is being stretched. So what you have to do is to remove this internal salient, so spinal cord has a better breathing space, and chances of progression of late onset neural deficit can be avoided, can be prevented. However, there are very poor chances of neural recovery if it is a true late onset paraplegia, true paraplegia with healed disease, because permanent changes in the spinal cord has taken place. So even if you remove this internal salient, there are very little chance of neural recovery. And this surgery is very difficult because while removing this internal salient, this risk of neural deterioration is always there. So patient has to be warned for that. So late onset, and this is one example I'm just showing for a dorsal spine lesion. And this is the late onset paraplegia, no active disease, So what we did is that we did the removal of internal salient, and one could see here, and that's how the decompression was done. Although there was some transient neural deterioration, a bed sore appeared, which has healed, but further deterioration, and patient has a reasonable preservation of neural deficit. At no stage this stage should never be allowed to reach by treating the active disease better. This is another example. You could see late onset, and that's how the internal salient was removed, and the spinal cord surgery for late onset decompression was done. So I think I did try to cover diagnosis in a presumptive TB spine case, early diagnosis before a classical lesion appears, ascertaining the diagnosis, and robust diagnosis and definitive diagnosis of tuberculosis should be made. I have talked about hierarchy of diagnosis, treatment, drug therapy, when, how much, how long, differences in adult children with deficit, without deficit, intervention, surgical, when, type of intervention, surgical approaches, drug resistance, how diagnosis can be made to the treatment, a word about TB spine in children, and paraplegia with healed disease. I did not cover granulomatous spinal TB because it is a very small subset of TB. So friends, thank you very much indeed. And if you have any question, you can put me onto this email. I should be able to answer for student all the time available. Thank you very much indeed.
Thank you, sir. Thank you very much, sir. That was an excellent and extensive talk about every aspect of tuberculosis of the spine. And we were able to understand every aspect, the pathology, diagnosis, and including the recent advances in TB spine treatment. That was indeed very informative, and loads of information were available, sir. Very happy to have you in this class. I think only a few doubts are there. Just one question from the attendees. He is asking how to differentiate between a bacterial discitis from a tuberculous discitis.
As I said, all efforts must be made to make a diagnosis. Well, there are clinical reasons to suspect tubercular versus bacterial discitis. Bacterial discitis, pyogenic discitis, they have a stormy presentation, high-grade fever, limited localized disease. While tubercular lesion, they have a grumbling presentation of a patient is symptomatic for long standing. Then after that, we come back to the general findings like presence of fever, high-grade fever, absence of fever, presence of comorbidity, absence of comorbidity. Then on X-rays, there are certain findings where you in a tuberculous lesion, one gets a classical, even in early stage, a demineralization. While in pyogenic, we get a increased sclerosis in disease of some standing. And then the investigation in the form of MRI, where preservation of disc or certain MRI finding of tuberculous lesion I have described vis-a-vis the pyogenic. I think by MRI, one is able to differentiate a pyogenic vis-a-vis tuberculosis, and then procuring the tissue and making a diagnosis. I would always like to say your diagnosis must be very clear before treating the case. But pyogenic generally have a stormy presentation.
Okay, sir. Clear, sir. Clear. One more question, sir. In case of drug resistance, how many days after giving category 1 treatment can we call it as drug resistance?
I think I will not call it months, because drug resistance is a diagnosis after culture. It is a bacterial demonstration of drug resistance. That is the drug resistance. And that is why I have coined in this article presumptive drug resistance. So, and that is why this term is now accepted even for the in the guidelines. We have used this term presumptive spinal TB or presumptive osteoarticular TB for initial case. and presumptive drug resistance case. So all those patients who after 5 to 6 months of ATD have no improvement in the system, in fact worsening of symptoms, appearance of a new lesion, or appearance of an abscess anywhere else, or wound dehiscence of an already operated lesions, continue to have, or appearance of a sinus, then probably the lesion is not, it is deteriorating. Then it is a case which is a suspected presumptive drug resistance case. Now, why I have put 5 to 6 months? Because pulmonary definition is 4 months, sputum conversion has not taken place on ATD, then they suspect for presumptive drug resistance. However, nowadays, in all programs, the emphasis is to make an early diagnosis. So even we can get tissue diagnosis early and submit for culture sensitivity or a molecular method, gene expert for rifampicin and LPA for rifampicin in INH. Because drug resistance is a bacteriological diagnosis unless you demonstrate by molecular or bacteriological method. We will not be able to treat the proper drug resistance.
Fine, sir. Fine. One last question, sir. Can we start ATT on clinico-radiological diagnosis alone, or should we always go for biopsy or molecular study to start ATT?
As I said, of late, see, we were talking in terms of a classical disease when the lesion was far advanced and it was obvious clinico-radiologically. Whether it is arthritis of a hip joint or arthritis of a knee joint. But now emphasis is on synovitis, an early stage of disease, or spinal lesion without deformity, where patient is symptomatic with subtle findings. In that case, we must have a diagnosis by any means. Now, I said by MRI, spinal lesions can be labeled almost 90% instance, but limb lesions, joint lesions for a synovitis stage, we will not be able to, by any MRI, we just can say that a patient has an inflammatory disease. So we must take all efforts to take a tissue, whether by any methods, from any joint, from any bone, or for that matter, even spinal lesion to ascertain the diagnosis. But robust diagnosis of a monoarticular joint disease or a spinal disease, a robust diagnosis must be there with us, and as early as possible. So, since we are aiming to diagnose in the early stage of disease, whether it is synovitis for a joint lesion, or an early arthritis for a joint lesion, or a prekyphotic deformity for a spinal lesion, and that is why more emphasis is to take a tissue if we do not have enough evidence to make a diagnosis.
Fine, sir. You have made it very clear, sir. Thank you, sir. I think there are no more questions, sir. So if there are any more questions, we'll mail you regarding it, and we'll send it to the attendees as well, sir. So thank you very much, sir, for sparing your time and coming for our session and teaching our postgraduates. I request Professor Eddy, sir, to say a few words.
Thank you, Anil. It was a very impressive and exhaustive lecture on bone and joint tuberculosis. As I expected, you've done extremely very well, being the authority on this subject. Thank you very much for giving your knowledge to all of us. I have also updated my knowledge because, as I always tell my students, you have to keep updating till you go to the grave. Thank you very much, Anil.
Thank you, sir. Thank you very much indeed, sir. Thank you, sir. Good night, sir. Good night. Sir.
Right.
Thank you very much, sir, and good night. And I thank all the attendees for attending this session. Thank you very much. And regarding our next session in this Professor Eddy's virtual clinics, it will be on 13th July. It will be by our guest faculty, Dr. C. Rex from Rex Ortho Hospital, Coimbatore. He'll be talking about objective structure clinical examination, which is going to be the next form of examination in DNB as well as MSR. So it will be a very informative talk by our faculty. Please do join us on 13th July at 8 p.m. Thank you all. Thank you very much. and good night.
Good night, all.
Good night, sir. Thank you, sir.